So our next speaker is Alice Shaw, who's an associate professor of medicine at Mass General Hospital. And the title of her talk is Targeting of Non-Small Cell Lung Cancer.
Thank you and good morning. Thanks to Bruce and the organizers for inviting me here today. Here are my disclosures. So today my topic is targeting non-small cell lung cancer, and I wrote in 2011 because a lot of progress has been made in just the last few years. And of course, this whole talk is really going to center on the concept that non-small cell lung cancer is really not a single disease. That's what we used to think. Now we actually appreciate that non-small cell lung cancer really comprises many different subtypes, each of which can be defined by a different genetic profile. And the hope, of course, is that the underlying genetics of the non-small cell lung cancer will dictate what the best and safest treatment is. So, for example, patients who have this green mutation will be treated with a drug that specifically targets that mutation and so forth. So I wanted to remind everyone about sort of the history of non-small cell lung cancer and what we've known about oncogenic drivers in non-small cell lung cancer. I would say before 2004, our understanding of the molecular basis of non-small cell lung cancer was rather limited. We have known for a long time that roughly 20 to 25% of lung cancers do harbor an activating KRAS mutation that's shown here in the blue. However, before 2004, this was really the extent of our molecular understanding of non-small cell lung cancer, and certainly this really had no implications for treatments. However, in 2004, a pivotal discovery was made, which was that there are activating EGFR mutations in a subset of non-small cell lung cancer patients, about 10 to 15% of patients. And of course, these mutations are important because they confer exquisite sensitivity to EGFR inhibitors such as gefitinib and erlotinib. And now, just 7 years later, we have a much more sophisticated understanding of some of the other oncogenic drivers in non-small cell lung cancer. And you can see here, we've now divided this pie into even smaller slices shown down here. The focus today, of course, will be on some of the smaller slices, but I would like to remind you that even smaller slices of the pie for non-small cell lung cancer can translate into large absolute numbers of patients. So, for example, ALK is present in roughly 3 to 5% of non-small cell lung cancer patients, and that actually translates into roughly 6,000 to 8,000 patients each year in the U.S. alone. You can also see from this pie chart that by this time now, we've actually identified in a little over 50% of cases the oncogenic drivers. So we clearly have made progress so that it's just a little under 50% of patients where we haven't yet identified what the key oncogenic driver is. So today, I'm going to focus on some of the newer targets. I'll begin with some of the sort of established targeted therapy paradigms in lung cancer with just a brief mention of EGFR, since that was the first sort of targetable mutation that was discovered. We'll focus a lot on ALK. There's been a lot of activity in ALK, and of course everyone knows that the ALK inhibitor crizotinib was recently approved by the FDA. We'll also spend some time on the newest kinase target in non-small cell lung cancer, which is ROS, and remarkably enough, ROS is also targeted by crizotinib. And finally, we'll end with just a slide or two discussing one of the major issues with targeted therapies, which is the development of resistance. So this is just to remind everybody of the key discovery that was made in 2004 of activating EGFR mutations in a small subset of non-small cell lung cancer patients. Dr. Lynch and Dr. Haber had noted that there were patients treated with the EGFR inhibitor Iressa or gefitinib that have very impressive responses, as shown here, and they went back and identified activating EGFR mutations, and this turns out to be the key predictor for response to EGFR tyrosine kinase inhibitors. These patients tended to be never or light smokers, women, and with adenocarcinoma histology. A lot of work has been done since that time, and I just wanted to highlight one sort of key aspect of our understanding of EGFR mutations and the role of EGFR mutations in selecting therapies. This is a key study that was carried out by Tony Mock and his group. This is the Ipass study published in the New England Journal in 2009. Here they identified patients with clinical features of EGFR mutations. They did not know EGFR mutation status up front. And these patients were randomized to receive either first-line chemotherapy with carboplatin and paclitaxel or gefitinib up front. And here the primary endpoint was progression-free survival. This slide summarizes what was seen with these patients based on their EGFR mutation status. So if patients turned out to have an EGFR mutation, you can see that the response rate was much higher to gefitinib compared to chemotherapy. And conversely, if the patient did not have an EGFR mutation, as shown here, the response rate was much higher to standard chemotherapy compared to gefitinib. Similarly, there was improved progression-free survival depending on mutation status. So those patients who had an EGFR mutation had improved PFS when treated with gefitinib compared to chemotherapy, and conversely, if they were EGFR mutation negative, they had improved PFS with standard chemotherapy. So this study was very important in suggesting that you must know your EGFR mutation status up front. And since that study, there have since been 4 subsequent randomized controlled studies looking at first-line EGFR TKI use compared to chemotherapy in patients who have EGFR mutation. They're summarized here below the Ipass study. And all of these studies show that in patients with an EGFR mutation, that first-line EGFR tyrosine kinase inhibitor therapy is superior to standard chemotherapy in terms of response rate and progression-free survival. And Ipass, it was also shown in terms of quality of life. Now, none of these studies have shown or are expected to show an overall survival benefit, because as you can imagine, those patients who are randomized to standard chemotherapy will eventually go on to receive the EGFR inhibitor in subsequent lines. But certainly the improvement in PFS and response rate is significant here. So this has really driven our current practice now of offering genotyping to all of our non-small cell lung cancer patients, because we want to identify those patients up front who have an EGFR mutation in order to offer those patients first-line EGFR tyrosine kinase inhibitor therapy. So one of the newest targets, I'm going to switch gears to ALK, which is one of the newest targets. And as many of you know, this is kind of a refresher. ALK was first discovered actually 15 years ago in the context of anaplastic large cell lymphoma. There it was discovered as a fusion with NPM or nucleophosmin. But ALK rearrangements were only discovered more recently in non-small cell lung cancer in 2007 by Dr. Hiromano's group in Japan. Actually, there what they did was a very traditional oncogene screen, where they created a cDNA library from a patient's lung adenocarcinoma and did a transformation screen using mouse 3T3 cells and identified cDNA that actually expressed a fusion of ALK, which stands for anaplastic lymphoma kinase, to a partner called EML4. And this led to the expression of a constitutively activated ALK, because the intracellular tyrosine kinase domain of ALK is fused to EML4. And this, they showed, and I'll show you in the next slide, this was oncogenic in vitro and in xenograft assays in vivo. We now know that there are other partners for ALK in non-small cell lung cancer besides EML4. There's also KIF5B ALK as well as TFG ALK, although the most common partner or fusion seems to be EML4 ALK. There are also ALK rearrangements in other diseases besides non-small cell lung cancer. As I mentioned, ALK was first discovered in the context of lymphoma. We do know that ALK rearrangements also occur in a rare type of sarcoma called inflammatory myofibroblastic tumor. And there may be other solid tumors as well that have ALK rearrangements. We do know that pediatric neuroblastomas do have ALK amplifications or ALK activating mutations. And there's been one recent report of anaplastic thyroid cancers also having activating ALK mutations. So ALK is a very important target in non-small cell lung cancer and will probably turn out to be an important target in other diseases as well. So this is from Dr. Mano's original report of EML4 ALK in non-small cell lung cancer, and this is showing the oncogenic activity of EML4 ALK in 3T3 assays and in nude mice. And the important thing here is that when they created an EML4 ALK that was kinase dead, you completely obliterated the oncogenic activity in both of these assays. So clearly it was the kinase function of the EML4 ALK fusion that was critical for transformation. They also used a small molecule to inhibit ALK and to show that the inhibition of ALK could lead to tumor regression as well. In subsequent studies, the settlement group here at MGH performed a cell line-based screen, actually not with crizotinib, but with a different ALK inhibitor, TAE684, screened a panel of cell lines and looked for sensitivity of these cell lines to this very potent ALK inhibitor. And what they found was that among the top 10 most sensitive cell lines to TAE 684, 9 of those were cell lines harboring abnormalities in ALK, so either ALK amplification, ALK mutations, or ALK rearrangement, suggesting that ALK could indeed be a very good target for cancer therapy. So with the discovery of EML4-ALK in lung cancer, the next question really was, well, how do we identify these patients? And here, Dr. Iafredi at Mass General started working on a diagnostic test. And what he used were commercially available probes from Abbott that are shown here in red and green. They flank the highly conserved translocation site within ALK. And in the presence of a rearrangement, these probes are now split apart, and you see splitting of the red and green signals as shown here, as compared to the fused signal, which shows up as a yellow. And so John was able to sort of optimize this assay. This is just to remind you that the FISH assay seems kind of simple in principle, but actually in practice it can be very tricky. There are many different splitting patterns. And here's one common variation that we see. We call it an isolated red or isolated 3', where you just see a red and you actually have loss of the green signal. So this is also a positive ALK case, and there can be other very subtle split signals. So this is somewhat of a challenging assay. In the beginning, when Dr. Iafredi was developing this assay, he did perform other assays to confirm the presence of ALK translocation. We can also confirm ALK rearrangement using RT-PCR for the exact EML4-ALK fusion or whatever the partner is fused to ALK. And we also can use immunohistochemistry with ALK-specific antibodies to detect the presence of ALK in the lung. ALK normally is not expressed at all in the adult lung, and so really there's no background here. And so when you see brown staining, that really indicates that the presence of an ALK rearrangement. So we have 3 different ways of identifying a patient with ALK, although the gold standard currently remains the FISH assay that was developed early on. So with this FISH assay in hand, we and others started screening patients to identify who could be the ALK positive patients and what the key clinical pathologic features are that are associated with ALK. And this is just a summary of the features that many case series have identified. We know that the ALK positive patients tend to be never or light smokers. They tend to be younger, on average about 10 to 15 years younger than the average non-small cell lung cancer patient. Unlike EGFR mutations, ALK rearrangements are not associated with any gender bias. Most patients have adenocarcinoma, and the specific type of adenocarcinoma tends to be a solid growth pattern, often with abundant signet ring cells. And then the other important thing about ALK rearrangement is that ALK does tend to be mutually exclusive with other key oncogenic drivers like EGFR and KRAS, so these tend to really not overlap in our patients. So knowing those clinical pathologic features was actually very important, because once we knew those, we were actually able to think about how to identify those patients. And the reason we wanted to identify those patients is because it just happened that there was already an ALK inhibitor in clinical trials. This is crizotinib, or PF-234-1066. It had already gone into a phase 1 dose escalation trial 1 year prior to Dr. Mano's discovery in 2007. And so with this trial up and running, the next really important step was to identify those patients that were ALK positive. And knowing the clinical pathologic features allowed investigators who were working on this trial to really hone in on a population of patients who we would predict would be clinically enriched for having an ALK rearrangement. So this is just to show you the structure of crizotinib and to show you that it is a dual MET and ALK inhibitor. You can see it does have, this is part of the kinase profile, and the top 2 kinases that are hit by crizotinib are MET and ALK, and these 2 kinases are predicted to be the only ones that are hit at physiologically relevant doses in patients. This is the dose escalation schema for the crizotinib phase 1 trial. And as I mentioned, we had already started this trial. Actually, this was started at 5 centers around the world, including MGH, and had started 1 year prior to even knowing about ALK and lung cancer. By the time we started identifying patients with ALK-positive lung cancer, the trial had already gone up to cohort 5, 300 milligrams twice daily. So we were already actually at a supratherapeutic dose when we enrolled the first ALK-positive patient in December of 2007, about 4 months after Dr. Mano's discovery. The trial had already been set up to not only include a dose escalation phase, but also then to have a dose expansion phase, and there was already interest in looking at molecularly enriched cohorts, although at the time the trial was initially designed, the main cohort of interest was going to be MET amplified solid tumors such as gastric and esophageal cancers. So we enrolled the first patients, as I said, in December of 2007 in this cohort, and this patient actually was one of these patients who was very sick when we first started and had one of these dramatic turnarounds. 6 months later, we enrolled a second ALK-positive patient. This was at the BI. And this patient also had a very dramatic turnaround, and this led then to I think a lot of interest in enrolling ALK patients from around the world into a dose expansion cohort for ALK-positive patients. And so that's what's shown here. This is data that was presented by Dr. Kamage at ASCO this past year. These are 119 patients who went onto the phase 1 trial. These patients were all prospectively screened for ALK rearrangement at 5 or 6 centers around the world. This summarizes the clinical characteristics of these patients, which is similar to what I showed you before. They tend to be younger, never or light smokers with adenocarcinoma histology. And here's the waterfall plot that was presented in just this past ASCO, showing you that almost all patients do have a response to crizotinib. The response rate here was 61%, but an additional 25 to 30% of patients do have a response, although they don't meet criteria for a partial response. And then there's really only a small proportion of patients, less than 10%, that for some reason, even though they do harbor ALK rearrangement, are intrinsically resistant to crizotinib. But really the key point here is that almost all patients do respond to this ALK inhibitor. Since then, we've gone on to show similar responses in the phase 2 trial. This was presented by Dr. Riley at World Lung this past summer. Again, you can see over 100 patients here treated on the phase 2 trial. Almost identical waterfall plots. Here it was, I believe, 51% response rate, but again, almost all patients do respond. We also now have some data on progression-free survival of these patients when treated with crizotinib. These are patients from the phase 1 trial, and you can see that the median progression-free survival was 10 months. This is very similar to what we see with EGFR inhibitors and EGFR mutant lung cancer, where many trials have now shown that the median progression-free survival in EGFR mutant patients is roughly 9 to 12 months with EGFR inhibitor therapy. So very similar to what we would predict, actually. We also now have some data suggesting that there may be an overall survival benefit, and you would expect this to be the case given the dramatic response rates and progression-free survivals that we've seen. This is data that we presented at ASCO this past year. This is actually a retrospective analysis. Here we had to compare patients from the phase 1 trial to a group of patients who had been screened around the same time, but for various reasons had never received crizotinib. So this is not part of a randomized trial. This was done retrospectively to try and get a sense of how much crizotinib may improve survival for these patients. The analysis was further complicated because we really had to narrow in on patients that we could feel were adequately matched from a clinical standpoint. So this is showing you patients who were treated with crizotinib as their second or third line therapy on the phase 1 trial. This is their overall survival here. And we compared those to patients also ALK positive, but for various reasons had never received crizotinib, but had received a standard therapy. And you can see their overall survival here. This difference was highly statistically significant, and the hazard ratio was 0.36, suggesting that crizotinib does indeed probably improve overall survival in these patients. What we've also seen besides the efficacy with crizotinib is we've seen very good safety. The safety profile is pretty impressive. By and large, most of the toxicities have been grade 1 with a few grade 2 toxicities. The most significant toxicities have probably been related to transaminitis. We've had a few cases of grade 3 and grade 4 transaminitis, and also a few cases of drug-induced pneumonitis. But overall, this drug is extremely well tolerated. So this leads us to the current state of crizotinib, at least in this country. And as many of you know, crizotinib was recently granted accelerated approval by the FDA. And I wanted to point out a couple of things about the label that are important for us to realize. So first of all, this approval was based purely on the response rate. So those two waterfall plots that I showed you from the phase 1 and phase 2 trials really is what led to this approval, not the progression-free survival or the overall survival, just really response rate, because that response rate really is so impressive in a group of non-small cell lung cancer patients. The second thing I wanted to point out is that the label is for both locally advanced as well as metastatic patients, not just metastatic patients. And the other thing I wanted to point out, which is very important, is that the label made no specification about prior lines of therapy, which is interesting to me because really the data from the phase 1 and of course the phase 2 trials are primarily from patients who have been previously treated. In the phase 1 trial, there were only 15 patients who received first-line crizotinib, so we have very, very limited data on first-line crizotinib use. But in those 15 patients, the response rate was 80%, and I've heard the progression-free survival was quite impressive, but the numbers are just very small. Nevertheless, I think given the EGFR precedent, as well as I think the impressive activity that was seen, the FDA approved this drug for use regardless of line, meaning that patients who are newly diagnosed with ALK-positive lung cancer can receive crizotinib in this country. Now, we do have several trials ongoing to better evaluate the comparison of crizotinib's activity to standard chemotherapy and possibly to get a glimpse into survival benefit. Profile 1007 is the second-line registration trial comparing crizotinib to standard second-line therapy, either pemetrexed or docetaxel. This trial is actually over 90% accrued at this point. It's been accruing at around, I believe, 170 sites around the world. We're nearing goal accrual. There's also the phase 2 trial. I showed you some data from that already. This phase 2 trial is both meant to capture those patients who were randomized to standard chemotherapy, then progressed. It allows those patients to technically cross over and receive crizotinib. And this phase 2 trial also captures all patients beyond second line. We now have, I believe, over 600 patients who are on the phase 2 trial. And there is an ongoing first-line trial as well, also accruing currently. This trial will randomize ALK-positive patients to either crizotinib or a standard first-line regimen of platinum and pemetrexed, and there will be crossover as well. Because of the crossover effect, we're expecting it will be difficult to actually know what the true overall survival benefit is of crizotinib, so the types of retrospective analysis that I showed you may really be our only real understanding of the survival benefit that's conferred by crizotinib. So this leads us now to kind of a more refined view of non-small cell lung cancer and how we should approach patients when we first meet them. Certainly, we and many others around the country believe in genotyping up front, now both to look for EGFR mutations and now also to look for the presence of ALK. If ALK is found, we can use crizotinib in the first-line setting as a standard therapy in this country, or we can consider enrollment on the first-line trial. So let's talk about the newest target in non-small cell lung cancer, and this is very exciting to us. This actually, ROS rearrangements were first discovered actually in the context of GBM, and this was done by a group at MIT, Dr. Hausman's group, where they discovered that ROS, which is also a receptor tyrosine kinase, can be rearranged and fused abnormally to a partner protein in GBM. It was found to be FIG. Although prior to even that, we knew that ROS was an oncogene that could be overexpressed and sometimes amplified in some GBMs. In 2007, also actually just a couple months after Dr. Mano's report of ALK in lung cancer, the cell signaling group out in Beverly reported findings from their technology. They called it phosphoscan technology. It's basically phosphotyrosine antibody pull down, where they're looking for activated tyrosine kinases. And what they found is that in one patient and in one cell line, they identified rearrangement of this ROS oncogene to either a protein SLC 3482 or CD74, suggesting that these fusions could be oncogenic in lung cancer. I should note that this group also found ALK fusions in non-small cell lung cancer as well. I showed you this slide a little bit earlier, and I wanted to point out that, as I mentioned, there were, of the top 10 cell lines that were sensitive to this ALK inhibitor, TAE684, in a screen performed by Jeff Settleman's group. 9 of those 10 had abnormalities in ALK, but one of those 10 was HCC78, which actually has a ROS rearrangement. So this suggested to us, even back in 2008, that ROS could be a target for an ALK inhibitor like TAE684. Now, why would this be? Well, it turns out that ROS and ALK are actually in the same family. It's the same insulin receptor superfamily, and they actually share a fair amount of homology within the tyrosine kinase domain, and that's shown here. This slide was put together by one of our collaborators, Ignatius at UC Irvine. So knowing that ROS could be a target of crizotinib and potentially other ALK inhibitors as well. Dr. Iafredi set out to, again, develop a diagnostic or screening test for ROS rearrangements in non-small cell lung cancer. He actually has some homegrown probes for doing this, and actually developed another split-apart FISH assay for ROS rearrangement. And working together with Vanderbilt, Dr. Powell's group, we started screening all of the non-small cell lung cancer patients both here and at Vanderbilt. And this is data that will be published soon in JCO. What we found is that ROS is rather rare. It's probably 3 or 4 times less common than ALK. It's present in 1 to 2% of our patients. And actually, interestingly, ROS patients seem to be very similar to ALK patients in terms of clinical path features. So they tend to be very young, very similar in age to the ALK patients, and they tend to be never or light smokers, also tend to be primarily adenocarcinoma histology. So once we started identifying ROS patients, we now started thinking about how we could treat them with crizotinib. And the trial actually has many different expansion cohorts, and one of them is a ROS expansion cohort. So I'm going to share with you a case that's part of the publication that's coming out soon. This is a patient of mine that we saw actually in February, but he had first been diagnosed in August of 2010. This is a young man, never smoker, originally from the Congo. And back in August of 2010, he was living in Georgia, still living in Georgia, and he was becoming increasingly short of breath, and his primary care doctor thought he might have asthma. So he was treated with different inhalers and antibiotics and things like that, but then it became clear that he wasn't improving, and in August he had this scan, which showed very diffuse disease. He underwent a bronchoscopy with biopsy, and it confirmed the presence of bronchoalveolar carcinoma, which we now call AIS, or adenocarcinoma in situ. Since he was a never smoker, he was started empirically on erlotinib. They did not have genetic testing back yet at that time. He did not experience any response to erlotinib, and actually was referred to us in February. So we met him at around this time when he was actually quite sick, and he was off treatment. And in February, we started doing some genetic testing for him. We found that he did not have an EGFR mutation, which we would expect given his lack of response to erlotinib. He did not have ALK rearrangement either. And at this point, we decided to test him for ROS. And actually, back in April, we finally got his ROS test back, and he actually was positive. So this is now where he is when we enrolled him on the phase 1 trial of crizotinib. So at this time in April, he was actually quite sick. As you can see, his lung disease had worsened significantly. He was very hypoxic, and he had a compensatory polycythemia with a hematocrit of 60. But because he was so young, he was actually in reasonably good shape. So we treated him with crizotinib at the standard dose of 250 milligrams twice a day. And this is the scan actually just 8 weeks later. And this is, again, a classic example of what we see with the EGFR mutant patients who get an EGFR inhibitor and our ALK patients who get crizotinib. Very similar type of transformation. In just a few days, he noticed a dramatic improvement in his breathing. By the time we saw him back at 2 weeks, he was already, well on his way to recovery, satting over 95% at that time. And in this scan, at 8 weeks, just confirmed what we saw clinically, that this patient really was responding well to crizotinib, and this was a very, what we call oncogene-addicted tumor. And he actually did meet criteria for 100% response. This patient continues to maintain his 100% response as of October. I just saw him a few weeks ago. So this is very exciting to us. There are more ROS patients who have gone on to the crizotinib trial, and ROS does seem to be sort of a very good target for crizotinib. So now I've modified this slide to show you that I think this is kind of a prediction for the future. Not only will we be screening for EGFR mutations and ALK, but we'll also be screening for ROS rearrangements as well, and probably at some point in the future be able to offer these patients a good targeted therapy like crizotinib in the first-line setting. So I'm just going to end on sort of the big challenge for targeted therapies, and Dr. Engelman's going to pick up on this and go into some of the more lab-based experiments. But of course, the big problem with targeted therapies is that patients do inevitably develop resistance. It typically occurs by about 1 year after treatment with the targeted therapy. This is a patient of mine who had a near complete CR after actually just 8 weeks of crizotinib. She had ALK-positive lung cancer, great response at 8 weeks, and then after a year, this is pretty much all she had left of her bronchoalveolar carcinoma. And then very slowly over the next year, she had progression of her multifocal lung infiltrates. And this is a common pattern that we see, that patients can slowly progress even while they're on crizotinib, still maintaining great clinical benefit, but their tumor is slowly growing back and becoming resistant. We have a lot of understanding of TKI resistance from the EGFR story, and I'm just sharing this with you. This is work that was done by Dr. Sequist and our group at Mass General, looking at different mechanisms of resistance in EGFR mutant lung cancer. And in a large series of patients that they rebiopsied, they found that there were several different mechanisms, and some of these we knew about before, of course. About half of the patients with EGFR mutations acquire a secondary T790M or gatekeeper mutation. There are other genetic changes as well, including activation of bypass tracks like MET and PI3 kinase. And interestingly, in about 14% of patients who become resistant to EGFR inhibitors, there can also be a change in histology to a small cell histology. So this idea of the different types of resistance mechanisms is similar to what we see in ALK. We also can see secondary resistance mutations as well as bypass tracks. Dr. Mano's group first reported the discovery of secondary ALK mutations actually about a year ago when he reported one patient who had benefited from crizotinib, had been doing well, became resistant. They rebiopsied this patient and found that he actually had two different resistance mutations, a gatekeeper, L1196M, which is analogous to T790M, as well as a different mutation in the kinase domain, C1156Y. And these mutations conferred resistance to crizotinib. We now know actually that there can be many different types of secondary resistance mutations in ALK. This is actually an in vitro study that was done by the Ariad group and reported at AACR about a year and a half ago, where they screened and found a number of different crizotinib resistance mutations, and you can see that they occur in all different areas of the tyrosine kinase domain of ALK, and we're beginning to see this in our patients as well, that there can be many different secondary resistance mutations. So unlike EGFR, where there really just seems to be one gatekeeper mutation, there are many different mutations that can occur in ALK, and Dr. Engelman will talk about this in a bit. So I wanted to end with just sort of a slide summarizing the time frame of crizotinib's development, which is pretty remarkable. Here's the first report of EML4 ALK in lung cancer in August of 2007. The studies that were done between the phase 1, phase 2, and phase 3 studies, and now, of course, just 4 years after that report, FDA approval in this country. So what is the future for crizotinib now that we have all this data? Well, there are, as I mentioned, other ALK-driven malignancies, such as anaplastic large cell lymphomas, IMTs, and probably other pediatric neuroblastomas, others that we're now looking at in terms of crizotinib's activity. We know now that there are other molecular targets of crizotinib besides ROS. Of course, there's MET, which was the original target for crizotinib. And a large focus, at least of our research and other people's research, is looking at how to overcome resistance to crizotinib and other targeted therapies, and using a number of different tools, such as second-generation ALK inhibitors that are more potent, structurally different, and also thinking about combinatorial approaches to overcoming resistance. So I'll just end with that pie chart that I showed you. And here the point of this is to emphasize not only do we know about all these oncogenic drivers in non-small cell lung cancer, but we're really beginning to make a lot of progress in matching these targets to targeted therapies, many of which, like crizotinib, are showing a lot of progress. So I'll end with acknowledgments, obviously the MGH thoracic group and pathology, particularly Dr. Iafredi. And of course, in terms of all the ALK work, there are many, many investigators from around the world who have worked incredibly hard on developing crizotinib, and in particular, I would recognize the Pfizer development team as well, and of course, our patients. Thank you very much.
Thank you, Alice. That was a great presentation. Maybe I'll start off and just ask you about what trials are ongoing right now for crizotinib failures?
A number of trials. So there are several different second-generation ALK inhibitors that are in the clinic already. Chugai has a compound that's in Japan that's actually already in phase 2 trials. Novartis has a second-generation ALK inhibitor. Astellas, I think there's altogether 4 ALK inhibitors that I know of that are in clinical trials in this country or in Asia. There are also some combinations that we're looking at. Pfizer had already been looking at a combination of crizotinib with the pan-HER inhibitor, PF-299804, that was initially primarily focused at EGFR mutant patients because, as I mentioned, EGFR mutant patients can develop MET amplification as a mechanism of resistance. Crizotinib targets MET. The idea had been to try and combine those two for EGFR-resistant patients, but of course, there could be a role for that combination in ALK-resistant patients as well. So I think there are combinations that are slowly percolating through, and some of them are already in the clinic.
HSP90 inhibitors?
Yep, and HSP90 inhibitors. So that's a very good question. IPI 504 is an HSP90 inhibitor made by Infinity that had been in a phase 2 trial actually several years ago, and there had been some response. Again, that had primarily been geared at EGFR resistant patients, and they had seen actually some reasonable responses lasting over 6 months. And when Dr. Sequist, together with Dr. Iafredi, went back and looked at the molecular genetics of those patients who responded, a few of those actually turned out to have ALK rearrangement, and that was really the first glimpse into the potential activity of HSP90 inhibitors in ALK rearranged lung cancers. And since then, a number of other HSP90 inhibitors have been tested in ALK patients. There certainly is activity in crizotinib-sensitive patients. Whether or not there will be activity in crizotinib-resistant patients, we don't know yet, but we're looking as well.
Oh, thank you. Bruce?
What happened with MET, the original target, in lung cancer particularly?
So there is activity in MET. There's already a case report in JTO, I believe about 6 months ago, showing activity of crizotinib in a MET amplified patient. There's another case report coming out as well. So there has been some activity that's been observed, and that's now going to be reported. How durable that is, though, is really the main question, and how good of a driver MET amplification is also not clear.
I have a question. So in the patients that have no smoking history, do you all ever evaluate whether they were pre-exposed as, are they secondhand smoke in a family or something like this? Is there anything that accounts for this early, event that might have caused some type of change?
It's a great question. We don't know, but it is very notable that both ALK and ROS and EGFR, of course, are very, very strongly linked to never smoking. It's clearly not these aren't smoking-related diseases. ALK and ROS are also notable because those patients definitely are younger than the average patient, and we don't have a good understanding of why that is. Certainly in our clinics, we will ask about other exposures, including secondhand smoke and any other exposures, but we haven't really been doing it in sort of a systematic way, and it's actually, as you can imagine, very hard to quantitate secondhand smoke. There are indices for doing that, but we don't really have that information. But I think going forward, that will be a very important question. I think it's probably a combination of some underlying genetic susceptibility as well as probably an environmental exposure that we just don't know about yet.
We have a question in the back.
Yep.
Thank you for your presentation. My question is, with the patients that are acquiring resistance to the targeted therapies, do you also start to see any changes in their response to chemotherapy, or have any of them been tried back on chemotherapy after they've developed resistance?
Yep, it's a good question. I think we don't have the answers quite yet. As you can imagine, many of these patients have only recently been on crizotinib, and we don't have that much post-crizotinib sort of follow-up on those patients. There can be different I would say kinetics of relapse, meaning the example I showed you was kind of a typical patient who's slowly progressing on crizotinib, but there can actually be patients who have quite rapid relapses once they become resistant to crizotinib, so there's kind of a spectrum in terms of how patients progress. I would say we've seen all different things after they progress in terms of whether or not they respond to chemo, and again, I think as we get more experience and more time to look at these patients, we'll have a better understanding of their chemo sensitivity both before and after crizotinib.
Martin?
Thank you. Alice, last year at the Chabner Colloquium #1, you presented a magnificent paper. This year it was equally magnificent, but you also got a gasp. When you showed those before and after of your first ROS patient, it was really spectacular. The fact that also, ironically, in just this 1 year period of time with the approval in August, I think August the 26th or thereabouts of crizotinib, today is the launch of Xalkori, crizotinib, and isn't it neat to have it launched in Boston? And the fellow who's going to be responsible for that launch is sitting right behind me. That's right. And I bet he'd like to say a few words. Mace Rothenberg.
You put me on the spot, Marty. Well, first I'd like to thank you, Alice and Jeff, and the whole team here at Mass General, John Iafredi, wherever he might be, has just really done a terrific job. When I talk about this, I really talk about this as a combination of good science, good collaboration, good communication, and good luck. So I think that this is really shows you the power of the ability of industry and academia to work together when it really works, how much it could help all of our patients. So thank you.